my humble and warm welcome on behalf of my whole team. I extend my welcome and special thanks to our respected chief guest, Dr. Sharda Jain, for joining us today and giving her valuable time. I also welcome our esteemed chairpersons, Dr. Sunanda Govil, Dr. Dipti Nabh, and Dr. Jyoti Malik. Now I welcome our vibrant and eminent speakers, Dr. Ragini Agrawal and Dr. Sunil Jindal, sir. Now I request our chief guest, Dr. Sharda Jain, who doesn't need any introduction, actually, to say few words of wisdom. And it gives me immense pleasure to introduce Sharda ma'am, who is a woman of many talents and principle. She is a great mentor and has very clear vision for the future. We all know that she is a great gynecologist and a great teacher of par excellence. She is a passionate medical social health worker and efficient organizer with a special quality of binding people together with a strong team. She is a founder of prestigious forum like Delhi Gynae Forum and WOW India. Presently, she is Secretary General of Delhi Gynae Forum. She has tremendous contributions on the campaigns of against female feticide and no home delivery and for no home delivery campaign. She is recipient of prestigious award of India Most Eminent Woman by the Human Rights Council. Her latest passions are protection of doctors, say no to cervical cancer, motivation of doctors to become healers. That means healers physically, spiritually, and emotionally. She is founder and director of Life Care Center and IVF East Delhi, and many more to her credits. So I request ma'am to say a few words of wisdom. Thank you.
Ma'am, please unmute yourself.
I bring greetings to you from the city of Delhi and congratulations to this particular society of FOGSI. The FOGSI is doing a great work on sexual health. The biggest proof is the Sexual Medicine Committee, which is working for some years. No doubt, sex is a very important aspect of human being. इसका दर्जा वो भूख shelter की उस basic needs में आता है. We were never taught sexual health during our undergraduate and postgraduate course. Whatever we know is our perception. जिंदगी के थप्पड़ों में जो हमें सिखाया वही हम सोचते हैं truth है. But we all know it is really tough. Type of sexual behavior, people like me cannot define what is normal. It varies so much. Varies in the same country, in different cultures, one can expect what all can be there. We do not know what is normal when it comes to sexual needs. मैं इसको कहती हूँ कि वो लंच की भूख जैसा है. कोई एक रोटी में satisfied है, कोई किसी को 20 रोटी चाहिए. And this is exactly what happens in sexual health. There are several people who like it many times a day. There are people who are happy with infrequent activities in the year. I will restrict my comments to adolescent and youth, and that too girls. It's good. India is a young India. Every fifth person is an adolescent here. But something very challenging with us is that 50% people are less than 25 years. Big task, big responsibility. I can only say, Today, the adolescent and the youth is sulky. Sulky because usko koi maa baap nahi hai. Nobody to give advice and guide them. They are vulnerable. They have confusion plus. और मैं कहती हूँ जब घर के लोग दूर हो जाए, बाहर के लोग अच्छे लगने लगे, तो जिंदगी में संकट आने वाला है. Parents are equally confused. उनको लगता है लड़की बड़ी, बिटिया बड़ी हो गई है, सब आता होगा इसको. So knowingly they refuse to tell. Teachers कहती हैं कल कर देंगे, परसों कर देंगे, सब कुछ there है. There is everything is there. But they do not teach. When I went to medical school, whenever a girl comes with a teenage pregnancy, it used to upset me throughout the day. When I became a faculty member, my stress became really big. And when I was blessed with my only child, daughter, I said, I must do something about it. And my roadmap was clear. What am I going to do? Being a gynecologist, you teach a lot of teachers. So in the next 20 years, we made a team. We did 1,000 workshops. I was joined by dozen gynecologists in the city who are big names now, and joined by 3 pediatricians. We did workshops in the school, colleges, government colleges, private colleges, medical colleges, dental colleges, engineering colleges. And I happened to become the chairman of the Women Wing of Indian Medical Association, the golden period of my time. And that time I traveled across the country, and UNFPA funded, and we trained 1,000 doctors in adolescent health. Here I wish to tell you, adolescent health workshops are serious workshops. They are skilled workshops. You have to teach people negotiation skills, how to say no. We were lucky. The government was sensitized. The manuals were made. Teachers' training program were flowed. We thought everything has been done. When I review 20 years later, the ground realities are the same. Parents don't talk. Teachers don't talk. Our gynecologist friend reached the school, पर वो menstrual health पे अटक जाते हैं. और वो भी इसलिए जो sanitary napkins बेचने वाला बंदा है, वो उनको ले जाता है. They don't do adolescent health workshop. It's a serious skill workshop. I think it should not remain to webinars. We must walk the talk. What has happened in the last 20 years? 20 years is ab bedhadak ho gaye, bhed chaal ho gayi. Sex is all around. Dar tha shuru mein, wo bhi khatam ho gaya. Living in relation is the norms. उनको लगता IPL तो है, वो देख लेगा. भूल जाते हैं contraceptive, भूल जाते हैं सब कुछ when they indulge in sex. And that is why I have a very small practice. I get 6 to 8 people with a background of IMs, IIT, big CAs, land up with HIV infection. Feel very sad. We have not done anything. We have to walk the talk. Talking on a webinars is not going to do anything. हमको seriously सीखना पड़ेगा and do something so the next generation is happy about it. The Western world has done it. They've streamlined everything. Right in the schools they teach. Nobody can say, I did not know, so I did not use a contraceptive. %, 85% of youth is. So a lot of effort has to be done by the Sexual Health Committee of FOGSI. And it should not be just on the words, it's just not the menstrual hygiene. It has to do a very big work. Big work means we need to be satisfied. वो एक जो IM में बैठा बंदा, अगर उसको कुछ नहीं मालूम है, आप सोच सकते क्या होगा? With these harsh words, my all wishes to this thing. I just want my years to roll back. So from my 73 years, I become a vibrant 43 years. I can definitely join you. It is too old for myself to go back to the schools and the colleges. But I think Vani, people like you can take a challenge, and that's what all about is. Thank you very much.
Thank you very much, ma'am. Ma'am, now we request you just to release our newsletter 3 of Sexual Medicine Committee. Ma'am, you're requested to release it.
I think I release this particular newsletter. This is newsletter 3, Sexual Medicine, and the contents will be eye-opener for everybody. And the contribution has been made by 2 gynecologists, and I think it's a great newsletter. And I think people like me will definitely benefit by this particular newsletter. I think this is all open to you from the Sexual Medicine Committee of FOGSI. Congratulations to you again, Vani ji.
Thank you, ma'am. Thank you very much. So now I invite our esteemed chairpersons. First chairperson of the day is Dr. Sunanda Govil, ma'am. She is very senior gynecologist practicing in Moderator. I think one of the pioneer gynecologists, private practitioner there. And she is a director of Navjeevan Hospital at Moderator. Our second esteemed chairperson is Dr. Dipti Nabh. Welcome, ma'am. She is also senior gynecologist practicing in East Delhi. She is director of Mother and Child Center, and she is present secretary of Delhi Gynae Forum East. And she is also the ex-treasurer of the same society. Now I welcome Dr. Jyoti Malik. She is also senior obstetrician and gynecologist and infertility specialist. She is director of JJ Hospital and Roots IVF, and she is secretary of Haryana Obs and Gynae Society. So I welcome all the chairpersons, and now over to the chairpersons for the invitation of the speakers. First speakers, Dr. Sunil Jindal sir. Dr. Sunanda ma'am, I request you to just introduce sir. Dr. Sunanda ma'am.
Yes. Okay. My voice is clear?
Yes, yes.
Okay. Thank you, Dr. Vani. It's my pleasure to introduce Dr. Sunil Jindal, MS, DNB, MNA, MS, FIAGE,
इसको भेजा था वो PDF की फाइल थी.
Yes.
इसको भेजी.
And
कोर्ट में गया था, वो कहते नहीं वर्ड में लाओ. टाइप करने में तो बहुत देर लगेगी.
Can I request everybody to mute their mics, please?
Affidavit पे.
it's my pleasure to introduce Dr. Sunil Jindal, MS, DNB, MNA, MS, FIAGES, IAGE. He is Chief Consultant, Laparoscopic Surgeon, Andrologist, and Reproductive Medicine Specialist of Jindal Hospital, Meerut. He is Scientific Director of Dr. Madhu Jindal Memorial Test Tube Baby Center, Meerut. Vice Chairman, Delhi ISAR, Delhi IAGE. Gold Medal of Best Postgraduate, MAMC, New Delhi. Over 250 awards from different organizations. Genetic male giving birth to twin Swerd syndrome, 5 TISA ICSI babies born together, series of patients of TIS and micro-TIS ICSI, 2 major ongoing studies in anthology, publication chapter in 8 textbook on fertility, over 200 national and international presentations. His special interest in fertility, enhancing gynecology, laparoscopic surgery, reproductive surgery, endolaparoscopic and micro.
Thank you very much. I can't hear you, ma'am. We can't hear you. You are mute, I think.
Sunanda ma'am, just unmute yourself.
मेरा introduction तो सुना था?
जी.
जी ma'am.
बट आपका गाना जरूर सुनना है कभी भी.
Thank for the fantastic introduction which was here. And before I begin, I would first of all request everybody to mute their mics, please. Could you please mute your mics, everybody? Thank you very much. Dr. Sharda Jain, thank you very much, ma'am, for being over here as, I would say, an inspiration, as you always are. I would like to also thank Dr. Vani Puri. And of course, Dr. Neeraj, I would always like to thank for inviting me to this beautiful occasion to speak about sexual medicine. We have three chairpersons, Dr. Sunanda, Dr. Dipti, and Dr. Jyoti Malik. Thank you very much for being here. And why I really wanted to talk about sexual medicine, and I have been speaking, is that because it is very less explored. The man and the woman who suffer from it do not come out with it. Adolescents, as rightly said by Dr. Sharda ma'am, are unaware. There is no sexual medicine teaching in schools or training in colleges. And more importantly, even we as doctors do not make our patients aware, whether it's a gynecologist, whether it's a surgeon, whether it's a urologist, whether it's a medicine specialist. I personally feel it is very important for all of us to look into this aspect as well, because if not us, who? And this is the reason that there are so many khandani shafakhanas which are open everywhere, जो सर्दियां शुरू होने पर कहते हैं कि खजाना तैयार कर लें, सर्दियां शुरू होने वाली हैं. I mean, and everybody flocks over there. I think it's very important for us to talk about the sexual part of it. And today in this program, we have two parts where Dr. Ragini Agrawal is going to speak about the female sexual dysfunction. And I would like to very simply and elaborately try to cover how do you evaluate a male. So I would begin my presentation. So the presentation is on evaluation of the male dysfunction. And in this male dysfunction, I would be covering a lot of things very quickly, but I would like to elaborate a few things. First of all, we need to understand that sexual dysfunction is a common condition, very common. And it also worsens the stress of infertility, of married life, of relationships, and above all, it is a very big stabilizing factor of life. Now, the male gender is very interesting. The male gender is interesting because every man thinks he's logical, stable, unemotional, except for at one place where the sexual judgment comes. And as Oscar Wilde has said, I can resist everything except temptation. And this is exactly the way men are. But there is a problem with men, and the problem is that men don't have a resource available to train them. There are no training programs available in colleges and schools. They do not share much amongst each other. Can you please stop annotating, please? I would request anybody who's annotating to not annotate. And Dr. Chandan, can you please mute yourself and stop the annotation, please? Yeah. Now, I would like to also come into the neglected area, this neglected area which is very important. And do we know that 35% of men and 54% of women suffer from this problem? Now, sex is different for different people. It could be naked men and women coupling for some. To the physician, it could be a cause of AIDS. To a moralist, sex is a taboo and it's a constraint of these social regulations. To an anatomist, there are only two alternatives, a man and a woman. But at the most basic level, sex is a genetic recombination. Mr. Rohit, can you please, since you are the administrator at the moment, could you please clear the annotations and could you also stop annotations? Because I do not have that with me to stop annotations. Vinod, are you listening to me? Can you get this annotation stopped, please?
Mr. Vinod?
Anyway, why is sex so misunderstood? Because no one knows its history and chemistry. And, you know, sex is something which has initiated rebellion, jealous rage, romantic fantasy, gambles, newborn babies. And it's a very, very powerful force and a mysterious force in our lives. Now, let's just try to understand first the male sexuality. There are a few questions which always come to us. One of them is, why do newborn babies have erections? Why do young boys play with their organs? Why do adolescents sleep more in prone position? Why do teenagers need their own space? Why do people fall in love and have a crush? Why do men go weak in their knees when they see a beautiful, attractive, sexy woman? And why does their entire body language, music, and behavior change when they see a beautiful woman? Now, why do men have extramarital affairs? Why does sex become so boring and tedious in middle age? And how does sexual inadequacy in 40s and 50s play a havoc with emotions as well as confidence? And why do even men at a later age still have sex on their mind? So we need to understand that sex is a chemical cocktail of hormones and neurotransmitters. And testosterone leads to the sexual, sensual, alluring, dark, dangerous overtones, and it's responsible for the aggressive sex drive. While estrogens in a woman make the woman receptive, the progesterone is a sex offender and it kills the sex drive. And oxytocin is the love hormone, which is the hormonal superglue and the crucial bonding agent for relationships. Serotonin, well, it can make you very demure or aggressive. And vasopressin is a hormone which is tempering on testosterone, which tends to make the man homogamous or monogamous particularly. Now, prolactin is the hormone of nursing, but it leads to impotence if it gets increased in a man. Dopamine, of course, is the hormone which drives you crazy, and it's the hormone of love. It's the hormone of happiness. It's just like cocaine. Just like cocaine drives dopamine up, love drives dopamine up. DHEA, DHEAS, they increase the sex appeal. Pheromones are sensed more in animals, less in humans. And phenylethylephrine is the molecule of love, the romance which is there within you. Now, male sexuality is a complex physiological procedure. And the maintenance of normal sexual function depends on the coordination of human multisystems, coordination of the nervous system, cardiovascular system, endocrine system, and the reproductive system. Now, in the normal male sexual function, explaining it very basically, there is an orgasm and there is ejaculation. And both are two separate procedures. Now in orgasm, there is an intense peak sensation, intense pleasure, altered state of consciousness, which is also associated with a reported physical change. Now, antegrade ejaculation is a complex physiological process which has two things with it. Number one, emission, and number two, expulsion. And this is because of the neurological and also the hormonal pathway. So if we see this diagram over here, we understand that the man has two corpora cavernosa. He has one corpora spongiosum. And the Dr. Bhavna Agrawal, could you mute yourself, please? Dr. Bhavna, can you mute yourself, please, madam?
और सुनो इसी के लिए ना जो भी गई है और इसकी सावित्री की छुट्टी कह रहा है सब
Bhavna ji, can you please, Mr. Sushil, can you,
परेशान हो गया है
Mr. Sushil, can you mute yourself? Yeah, thank you very much. Now, then there is, of course, the corpora spongiosum, and the corpora spongiosum is what turns into the glans penis. Now, the sensations from this, as well as the methodology of having an erection, sustaining an erection, has a very big neurological path, which I would be talking to you about briefly, but not too much about it because I would mainly concentrate on how can you evaluate. Now, the first thing for us to understand how frequent it is. Well, if you look at men around 50 years of age, there is about a 50% probability among them for having any kind of sexual dysfunction. And as the age increases, it is seen that the chances of sexual dysfunction or erectile dysfunction increases. Now, what is the mechanism of an erection? So the corpora have sinusoids, and when they are filled by arterial dilatation, the veins which take back the blood are compressed. And so what happens is that the blood stays within the sinusoids of the corpora, leading to the erection, and these do not go back into the venous flows because of the erection, they get collapsed. In fact, you just understand that if there is a sink and it is filled with water, so the arterial flow is the tap, which is on, the sink is the sinusoids, and the rubber bung which you put in is the venous outlet. And the control of these three things lead to the presence of the erection, and later on, of course, when the erection is over, it would be normally the time when the venous output is going to flow. Now, this is a diagrammatic representation. Now, what happens in this is that if you see over here, you have normally the blood coming in and this blood going through the outflow. But when there is an erection, there is a good arterial flow, and the compression of the tunical venules leads to stoppage of the outflow, and this leads to the erection. Now, there is one thing interesting, that the penis is like a heart. Men with erectile dysfunction have twice as a likely chance of having a heart attack than a normal, and risk is similar to smoking or a family history. Now, erectile dysfunction, well, it can be a marker of heart disease. It is related to the overall health. Eating well, sleeping well, reducing stress, exercise, and getting testosterone right is important for all men. Now, a few things before I start on the evaluation which I'd like to bring out here is that these are endothelial cells. In the heart, they're endothelial cells, and the pathway is closely the same. And 2/3 of men with hypertension have some degree of erectile dysfunction. 60% of men with ED have undiagnosed lipid abnormalities, and more than half the men with ED have no cardiac symptoms but have an abnormal stress test, and 40% have been found to have significant coronary artery disease when studied. Of men hospitalized for their first myocardial infarction, 64% had ED with the onset of 3 years or more before infarction. So it beautifully correlates with the cardiac problems, the hypertension and dyslipidemia. Now, this is a chart which I normally use for my patients. So I normally would ask them, how do you rate your confidence that you could get to keep an erection? Number two, I ask them, when you had an erection with sexual stimulation, how often was it enough for penetration? During sexual intercourse, how often were you able to maintain? During sexual intercourse, how difficult was it to maintain to the completion of intercourse? And most importantly, when you attempted sexual intercourse, how often was it satisfactory for you? So if you mark all of these, and if the total is less than 21, then you can consider some sort of erectile dysfunction. The prevalence, of course, is very high in people with depression, post-myocardial infarction, diabetes, hypertension. Overall, it's about 10%, and in cigarette smokers, about 20%. Now, male sexual dysfunction can be either decreased libido, erectile dysfunction, or ejaculatory dysfunction. Three things can be there. So, first of all, let us go to something which is the hypoactive sexual desire. Now, the Diagnostic Statistical Manual has defined hypoactive sexual desire as persistent or recurrently deficient sexual fantasy or desire for sexual activity. And do we know that this is seen in up to 15% of adult men? And low libido is often secondary to medication, depression, systemic illness, low testosterone, but it can also be psychogenic causes. And low testosterone is very often related to the low libido. Men with erectile dysfunction may experience loss of libido secondary to sexual dysfunction. So the man is there who goes for a sexual act, he's not able to have the sexual act, he gets into anxiety and fear, and the libido goes down. That's one method, which there's something which happens very often. Now, what is the scheme in the hypoactive sexual desire? So either it is the change in the hormones, which is the testosterone and estrogens, or what happens is that there is a cognitive restructuring which takes place because of the sexual self-view which people have, a few positive romantic relations and sexual encounters which may have been. Can you please mute yourself, anybody who's unmuted, please? And a few positive romantic relationships and sexual encounters which may have taken place. Now what happens is that this goes into the history of sexual activity and brings a man to a place where he actually goes into a low libido stage. There is something else which can happen, and that is the protective partner factors. Now please, you will need to understand this. We get a lot of patients of vaginismus, and these patients of vaginismus, or these girls with vaginismus, when you ask their husbands, they would normally say, my husband doesn't have a desire to have intercourse. He's not interested in sex. When you ask these questions from the husband, you realize the husband has normal erections, but out of love and protection for his partner, his libido goes down. Because That's the way he can exist without being aggressive and hurting the partner. So because he doesn't want to hurt the partner, the libido goes down. Now, a lot of people, especially in women it is more, in men it is less, have sexual aversion. Now, this can be because of sexual anxiety, some trauma during childhood, a negative sexual scheme in the mind, low arousal, and in terms it leads to avoidance. And this sexual anxiety leads to sexual aversion. Please understand, in a woman you can see it from vaginismus. In a lot of men, you could make it out because there is an aversion. There's another part of it I'll just share with you. I had a patient coming to me who was a very high official in a company. So he had got married, and the husband-wife came to me, and the wife said that he is not interested in me at all. So when I spoke to him, he said that he was a homosexual and he had aversion to any sexual, I would say, activity towards a woman. So this kind of an aversion could also be there, which could be linked to the person's sexual identity. This is another area which needs to be looked into. Now, erectile dysfunction. If you ask me about erectile dysfunction, it is also called impotence. And it is defined as the persistent inability to maintain an erection sufficient for satisfactory sexual performance. And this is prevalent in up to 52% of ED is there in a large population of people, which could be there from 40 to 70 years. Now, if you look at the erectile dysfunction case formulation, you would need to understand that it is a whole structure of so many different pathways together. There can be organic factors like vasculogenic factors, along with medication side effects which the person may be taking. These could lead to low arousal. There could be dysfunctional attentional processes, which again could be lead to low arousal. There could be factors which are emotional, which could be leading to anxiety. There can be low sexual experiences which this man has had, which could further on lead to anxiety. And these along with together inhibit the parasympathetic pathway and lead to low arousal, which also leads to erectile dysfunction. Now, how would you evaluate? Now, I have just made an algorithm of how I normally would evaluate. So I would ask, is there any sexual problem or not? If there is yes, we would go ahead. If there is no need to go into any further evaluation. Now, in the sexual problem, we would like to ask, is there any erectile dysfunction? If there is no erectile dysfunction, I would like to evaluate the other sexual disorders. But in case there is erectile dysfunction, I would like to take a detailed medical, sexual, social history, a focused physical examination, laboratory evaluation, and I would like to screen for any diseases like dyslipidemia, any diseases which could be focused on the blood profiles. I would like to see the hormonal profiles as testosterone and prolactin. Mr. Vinod, are you there? Vinod, are you there?
Yes, sir. Yes, sir.
Can you please ask the support team to stop the annotation? And can you please also, I mean, nobody should be able to annotate except for me, because somebody is scribbling on the board. And can you ask them to clear it? Because I'm not able to clear it, only the support will be able to clear it. Is it okay, Vinod?
Yes, sir.
Yes, sir. Okay.
Just give me a moment. I will ask my support team to clear it.
Right. So now what happens is that once you have done this, you would like to treat the medical condition and modify the medication regimen. Now there can be three things to it. There can be a persistent erectile dysfunction which still is there, despite you stopping modifying the medicines, treating the medical conditions, still you would find a persistent erectile dysfunction. So now you're going to judge whether it is psychogenic, whether it is neurogenic, or whether it is vasculogenic. Now, how would you judge this? This I would come into another slide. And once you have judged the patient as psychogenic, you would consider sex therapy. You would like to give him oral medication. You could give him intraurethral medications, vacuum devices, and along with therapy, it can be corrected. In case there is neurogenic, again, you would do the same thing. But in vasculogenic causes, you would have to do an extensive evaluation to see what needs to be done further. Now, if we come to over here, the detailed medical, sexual, and social history, focused physical examination, laboratory evaluation, if you find testosterone and prolactin, if you find these hormones, which means especially testosterone and prolactin abnormal, you would like to go ahead further to see if the LH and FSH are normal. If the LH and FSH are high, it means there is a primary testicular failure. And if the LH and FSH are low, it means there is hypogonadotrophic hypogonadism. And if there is a high prolactin, you would like to do an imaging done to see if there is any tumor or not. And if there is no tumor, you would like to give these patients bromocriptine or Caberlin, and you would like to give these two drugs to treat the high prolactin. Now, what are the diseases? What are the diseases with which you possibly can have these conditions? So let us now understand. You need to take a history of diabetes, heart disease, hypertension, lipid disorder, renal failure, liver disease, and vascular disease. You need to see endocrinally if this person has hypogonadism. You would like to do the testosterone, LH, FSH, testosterone, prolactin, and thyroid. You would like to see the lifestyle if he smokes or if there is chronic alcoholic abuse. And you would also ask a history of any kind of a spinal injury, multiple sclerosis, or any disc which has herniated. Along with that, you would also ask if there has been any injury to the penis or to the pelvis. Now, what are the drugs which affect? Now, this is very important for you to understand. This is a very important slide. In case the man is getting thiazides and spironolactone, he can have low libido and erectile dysfunction. Anybody who's having methyl dopamine clonidine is going to have the same problem. People who have alpha blockers and beta blockers, alpha blockers particularly, and beta blockers, if they are non-selective, they lead to decreased libido and erectile dysfunction. Can you please off your mic, those who have it on, please? Mr. Vinod? Mr. Vinod?
Yes, sir. Tell me, sir.
Can you make the administrator please make all the mics off and the annotation off, please?
Yes, sir. I just cross-checked with my support team. You need to reshare your presentation and you have on this highlight option in your case only. That is why this lining are coming there.
Okay.
So you need to stop sharing and again you need to share your presentation. Then
Okay,
it will go out.
I'll just stop for a minute. I was talking of the drugs. Now, those people who are on antidepressants and antipsychotics have this problem. And patients with benzodiazepines also have these problems. Alcohol, whenever taken chronically, phenytoin, phenobarbital, as well as ketoconazole. Now, when you take a history, you would like to judge from the history whether this man has a psychogenic problem or it's an organic problem. So you would normally ask the age of onset, any specific event, has it been gradual or sudden? If it is sudden, then probably it's psychogenic. If it is related to an instance, it is probably psychogenic. Whether there are nocturnal erections or not, if there are not nocturnal erections, it probably is psychogenic. Does it happen with different partners? I still have a patient, I still remember, who one day came and told me he just cannot have sex with his wife. And I asked him, are you able to have it anywhere else? And he said, fine, absolutely fine, no problems at all. And he came to me to get his erectile dysfunction treated. And this little history can give you so many things about what is the cause of this problem. Now, the presence of dysfunction, and you'd also like to ask them a few problems about loss of libido, whether these people had some recent sexual encounter. Now, if it is organic, there would probably be a chronic disease. It would be slowly over a period of time. This man would probably be a smoker. And this man would probably be having something like hypertension and heart disease. And one thing which is very important in this is sleep apnea. Those people who are obese and have sleep apnea, 70% of people with sleep apnea have erectile dysfunction. When a woman comes to me and says, मेरे husband खुराटे बहुत लेते हैं, रात को करवटें बदलते हैं, and मेरे साथ relationship बहुत poor है, I send them to the pulmonologist immediately, and they always turn out to be sleep apnea. Now, these psychological causes, they could be the young age, specific emotional event, dysfunction in certain settings, there are nocturnal erections, previous history of erectile dysfunction, and it became okay. You get so many patients who say, ये तो जी मुझे होता ही रहता है. And when you talk to them, ये होता रहता है क्या मतलब? बोला जी कभी होता है फिर ठीक हो जाता है. If there is a stress in life, and if there is depression, psychosis. Now, organic would be most normally vasculogenic. And this would be when there is persistent interest in sex, the man has interest in sex, older age group, chronic diseases, smoking. And these people normally come to you and tell you that, well, they do not have nocturnal erections or they are less. Now, you need to first of all find whether it's a vasculogenic cause, a neurogenic cause, or a hormonal cause. And that's very important. Now, the laboratory investigations which we normally would get done are a fasting glucose, lipid profile, hormonal profile, thyroid, PSA, and prolactin. Now, the first line of evaluation normally in these men, if the person you feel is vasculogenic, you could do an intracavernosal injection, which normally can be a papaverine or a papaverine with phentolamine. And this allows a bypass of the neurogenic and hormonal influence. So all it shows to us is the vascular part of it. And it's a very useful and a very simple test to do. Now, the second line, which is very good, is normally a color Doppler ultrasound, where you would like to see if the peak systolic flow after injection is more than 35, in fact, even 30 would be fine, centimeters per second. And the end diastolic velocity, it has to be less than 5, then it is normal. Doppler scanning can also be done, but color Doppler is fantastic. So I would just show you this video. So you can see over here the corpora, the 3 corpora. And in these patients, when you do a color Doppler, unfortunately, I think I loaded the wrong video. Otherwise, I would have shown you the full procedure of a penile Doppler. So what you do in a penile Doppler is, you first take an ultrasound in the flaccid state, then you inject the penis with papaverine, and once it is erect and rigid, you calculate the flow in the cavernosal arteries. If the flow in the cavernosal artery is more than 25 or 30 centimeters per second, then it is great and normal. If it is less, then you understand that there is a vasculogenic problem. You also calculate the vascular flow in the veins, and if the vascular flow is less than 4, it is fine. If there is more than 4, then it is a venous problem in these people. Now, what is the aim? Our aim is simple. We want to improve the libido, address 2 vital questions: the capacity to acquire a sustained erection for intercourse, and to prevent premature ejaculation. This is what we actually want to do. Now, for erectile dysfunction, you have drugs available today as sildenafil, tadalafil, vardenafil. You have alpha blockers. You have vacuum constricting devices. There are behavioral therapies. In case a person comes to you and he doesn't, with sildenafil, there is no effect, you can give him intracavernosal injections. Suppositories are not available. And of course, in the end, if this does not help, you would need to do a penile prosthesis operation, either semi-rigid or inflatable. Now the approach is just as I had spoken to you, but I would just speak a little bit about phosphodiesterase 5 inhibitors, what we normally call as Viagra. So it could be sildenafil, it could be vardenafil, it can be tadalafil, avanafil, but in our country what is normally available is sildenafil and tadalafil. Now, the guidelines of the American Urological Association say it's the first-line treatment in ED unless the patient has contraindication. And insufficient evidence supports the superiority of any one over another. There is another very important thing for us to understand, that the choice of drug is dependent on whether you want it for a single intercourse or you want it as a regular therapy. So if you want for a single intercourse, or sometimes sildenafil is the drug, and if you want it over a period of time normally, then tadalafil is the drug. Now, the best thing about it is it produces natural erections. But stimulation needs to be there. And if stimulation is not there, then it is a problem because this drug will not act. So a lot of people who come to me, whenever I give them sildenafil, I tell them 2 things. Number 1, you have to go into the erotic zone. And I always tell the partner, you have to make this man feel needed. Only then this drug is going to work. And it enhances the relaxant effect of nitric oxide on the corpora. It is an effective treatment of erectile dysfunction with broad spectrum etiology. There's nothing like iski aadat pad jayegi, ya drug tolerance to this, or tachyphylaxis. And side effects are not too much. It's very well tolerated. So that's not a problem at all with this drug. So what does this drug do? See, we understand one small thing, that nitric oxide is needed, which stimulates the guanylate cyclase. It converts GDP to cyclic GMP. And cyclic GMP leads to the relaxation of the sinusoids. Now, if this cyclic GMP is degraded fast into GMP, the relaxation will not take place or will be less. So what PDE5 inhibitors do is, they prevent the breaking of the cyclic GMP into GMP. And this is why there is an erection because of the action on cyclic GMP. So cyclic GMP level increases and the erection is present. Now, in a intracavernosal injection, which is a self-injection which we treat, these are the injection sites. And once the patient injects, is able to have a sustained erection for intercourse. Now, another important thing for us to understand is that you need to get the testosterone level down. And if the testosterone level is down, you need to give these men testosterone, which is best given in the form of a gel. It enhances the libido, overall well-being, and also leads to a better effect of the phosphodiesterase inhibitors. And in patients in whom the phosphodiesterase inhibitors are not working, in these patients, when you give them testosterone, if it is low, they start functioning. So I would come to premature ejaculation now. Well, premature ejaculation is something which also leads to problems in about 29% of population. And it's very interesting because ejaculation that always or nearly always occurs before or within 1 minute of vaginal penetration is premature ejaculation, or it is the inability to delay ejaculation on all or nearly all means after vaginal penetration. And it leads to a lot of distress, it bothers, frustration, and it leads to avoidance of sexual intimacy.
अब बिना ऑयलिंग के चलाएगा तो साइकिल तो अटकेगी ना। शिट यार रुचि, इन लड़कों को कौन समझाए? तुझे पता है एक बार राइड के लिए मैं खुद से ऑयल लेके गई थी। फिर क्या 2 बार पैडल मारा नहीं कि बस पहुंच गया अपनी मंजिल। फिर बेट पे तो ऐसे डींगे हांकेगे ना, कह रहा था जो जीता वही सिखाता 10 बार देखी है मैंने। आई एम द बेस्ट राइडर यू विल एवर। हाँ, फिर क्या 2 मिनट में उतर गया होगा? नहीं, अरे भाई इससे अच्छा तो घर पे पैदल चल लो भैया जी, अकेले हमारा क्यों टाइम वेस्ट कर रहे हो यार? डेट पे साइकिलिंग कौन करता है?
This is exactly what happens, and it leads to phenomenal distress among boys as well, young boys, not only in adult, senior people, but even young boys. Now, premature ejaculation case formulation. If you look at it, there would be probably low sexual experiences which have happened because of premature ejaculation. And this leads to, or this man has a high arousal sensitivity. They're very highly arousable. It leads to premature
So we can't hear you.
Yeah, I think I'm back. My internet had an issue, so I'm back. So in premature ejaculation, you would have a high arousal sensitivity, and this would lead to an avoidance ultimately to increase it. Now there are a lot of techniques which are there, which are used. There could be start-stop technique, squeeze technique, masturbational techniques, which are behavioral therapies. But along with that, you also have paroxetine, sertraline, clomipirine, and duloxetine, which is on demand, which is used a lot. And topical creams like lidocaine and prilocaine can also be used. I would not go further into the details of this, but I'll bring a few facts to you, which would be interesting. I mean, they're just interesting facts. That most men with erectile dysfunction do not actually have erectile dysfunction. These men have anxiety or a thought that they have erectile dysfunction. There is a very major problem that people actually believe that they would be lasting for a very long time. And the pornographic movies and literature has brought it to a place where people think that they last too much. And it at times is not erectile dysfunction, but the thought that they have erectile dysfunction. Penises are fragile and they can have fractures. Erections happen early. Medications for ED does not always work. A lot of men come to me who say they have very short penises, but shorter penises, you always ask them if their erection size is fine, and normally the erection is good. What we need to understand is that the average erection is 5.6 inches and the normal duration of intercourse is 3 to 5 minutes. I got this patient about, I would say, it was I think 2 months back. She came with her husband. I asked the husband, what is the problem? The husband said, there is no problem. And I asked the wife, what is the problem? She said, he does not last. I asked him, how much does he normally last? She said, only 5 to 10 minutes. And that was a time when I actually had to counsel them that the normal duration is not as it is seen in movies, but the normal duration is about 3 to 5 minutes only. So we need to understand all these facts when patients come to us. Modern andrology can offer cure to nearly all patients with impotence. And we need to remember that a person may be born with erectile dysfunction, but he need not die with it. And this is something which is very important. And I would just like to thank all of you for the time given to me and being such a wonderful audience. If there are any questions which you have, I would love to answer them for you. Thank you very much.
Thank you very much, sir, for the nice, knowledgeable lecture. Now I request Dr. Jyoti Malik to invite Dr. Ragini Agrawal.